I've always wanted to do a talk on pneumothorax because I think the use of lung scanning's received a very good rap and people assume it will be easy, but in actual fact, scanning for pneumothorax I think is one of the harder techniques in lung scanning. I'd like to put to you that it is really juggling between three things: the accuracy, the feasibility, and the stakes. When you're a medical student, the simple view of investigation for pneumothorax was quite linear. One developed a clinical uh, suspicion, one proceeded to a bedside scan, and then, if that wasn't certain, onto a CT scan. But unfortunately, in real life, it's nowhere near as simple as this. For example, consider the situations. An aerial retrieval of a multi-trauma. You might even forego the clinical examination and go straight to a presumptive thoracotomy. A fit young patient comes into your ED, can certainly wait for a chest X-ray. However, what happens if the same problem happens in second stage labour or in a country town? At the other end of the spectrum, we have the critically ill ventilated patients in whom, so far, only supine chest X-ray has been available. And of course, there are the patients with the very complex diseases in whom only CT will tell you what has really gone. So let's look at investigation of pneumothorax as a decision that we have to consider three trade-offs. The first two are easy to map. They're to do with the test. They are the feasibility and the accuracy. Clinical examination, of course, is very feasible, but its accuracy is as good as the clinician. Lung ultrasound is a lot more feasible, though a lot more accurate rather, not quite so feasible, but still something you could take to the roadside. Chest X-ray has perhaps a wider margin of accuracy, somewhat less feasible. And CT, of course, is the gold standard for accuracy, but the least feasible. Chest X-ray is best in the supine patient and best when you can measure the erect patient. Lung ultrasound, on the other hand, suffers more in abnormal lungs and is most accurate in people with normal lungs. We'll discuss the reasons for that later. So what's the third parameter? That has nothing to test and a lot more to do with the patient themselves. We have to look at the risks versus the stakes in the individual situation. Another way of looking at this is to ask yourself, what are the consequences of missing a small pneumothorax? And at the other end of the spectrum, what are the consequences of an unnecessary thoracotomy or thoracostomy? And finally, and this is mostly to do with CT scanning, what are the consequences of performing this test, of taking this patient out of this environment to another place? So, first thing I want you to keep in the front of your mind is that this is about the risks versus the stakes. Let's look at the evidence now. There are two meta-analyses. The one in Chest 2012 looked at lung ultrasound versus supine chest X-ray. And I don't think there's too much doubt by now that supine chest X-ray is not the way to go if you're looking for pneumothorax. An erect chest X-ray is better, and when I looked at this second meta-analysis of lung scanning versus erect chest X-ray, I was a little bit surprised they did so well on the lung scanning. You'll see the main gain is that lung scanning is more sensitive rather than specific. Since these analyses, there's been a few more papers out in blunt trauma, where again the patients are more likely to have normal lungs. Lung ultrasound does still perform better than supine chest X-ray. However, when we start using this technique in patients with abnormal lungs, and this last paper was in patients who were receiving procedures such as fluorescentesis and lung biopsies, we notice that lung ultrasound is starting to lose specificity, whereas erect chest X-ray certainly outperforms lung scanning in this situation. And I think the reason for this is that it's quite hard to scan in the supraclavicular fossa for lung scanning, and at the same time this is where you often get BULLAE, which will give you the appearance of a pneumothorax. So if we were to in some way summarize I think what the literature is showing us, I think it's fairly definite that supine chest X-ray is not much use. Lung scanning can outperform. But I would say, depending on how long you have to perform your scans, in general, your erect chest X-ray is probably just a bit better than your lung scanning in normal lungs. And then the both bedside tests, erect chest X-ray and lung scanning, are far inferior to CT scanning when you have abnormal lungs. Talk more about that later. The easiest thing to remember, I think, is that lung scanning is more sensitive, but chest X-ray is more specific. And again, this is to do with normal lungs. The method is the same method for any scanning. You have to acquire the views and you have a choice of probes. You then have to analyze the movement, and this is the most important thing. Pneumothorax scanning is about analyzing movement. And finally, you have to interpret it in the context of the patient. And again, abnormal versus normal lungs. So your curved probe will show you a larger area. You can canvas a lot more area with a curved probe. You see deeper, which isn't very important when you're looking at a pleural surface. And there is less movement artifact. Now this is a mixed blessing. Your straight probe takes a lot longer to get around the chest surface. You do see much more pleural detail, and you see more movement artifact. Again, mixed blessing this is. If I showed you a picture like this and asked you, is this a pneumothorax? There is no way anyone could tell you either way. You have to look at a moving picture and separately identify 3 different types of movement. Now, they can be present in any combination, so separate out in your mind, first of all, what is the heave of respiratory effort? Secondly, you look for sideways slide of the pleura. This is most obvious as it disappears just beneath ribs. And finally, you look for a twinkle of live pleura. Now, don't exactly know what causes this, whether it's just slide end on, whether it's vascularity, but it makes the pleural edge look alive. So if you have a look at this picture, you can see the overall movement of respiratory heave, and secondly you can see the pleura sliding, particularly at the top left of the picture. That's that white line going underneath the rib. There's not a very good view of twinkle simply because it's got such a large depth. Here's another view where on the left we have the lung sliding in and out under the rib, and on the right we have the dead white edge of pleura. Looks exactly the same, looks continuous, but just doesn't have that extra twinkle. Have a look at this picture. First of all, look for respiratory heave, then focus on that white pleural line below the rib edge and tell me if you think there is any movement under the rib or any twinkle. Now this one I found in a pile of pneumothorax scans, and it could for all the world be a pneumothorax. There's no relative movement of that white line, but I also think I'd be very worried whether this is a rib fracture. This is one of the reasons, or one of the traps and tricks in pneumothorax scanning. Have a look at this one. Look for the respiratory heave. Then look at the pleural surface and try and decide if there's any twinkle or slide on that. It can be quite difficult separating these three movements out. Easier with a straight probe. You can see live pleura on the left, the rib shadow, leading edge of the rib surface, and then dead pleura on the far right. The lung point presumably was somewhere under the rib. Now this is a tricky one which we'll come back to later. There's cartilaginous rib in the center of the field, which is why you can see the pleural surface extending underneath the rib. If you look at the edges, there's an impression of twinkling, but the middle looks quite dead. Show you what that looks like later. But lesson number 3, the summary is we're looking for heave, slide and twinkle in any combination. Now when the movement is hard to see, we have an extra tool to use, and that's M mode. M mode is your single line of sight view, a bit like time photography. You put your M mode cursor down through the pleura and watch what happens. This is what used to be called the seashore or Shelley Beach sign. Now it's just called sliding. Make sure that you measure down to the pleural edge in pictures like this where they're not side by side. In this picture, the pleural edge is about 2 centimeters below the surface, and so that's the white line on the M mode, about 2 centimeters below the surface. And you can see there are more ripples or shells on the beach or waves beneath that white line than there is above. The important thing we're trying to show is that there is relative movement with the pleura compared to above. Here's the alternative. This is called a stratosphere or barcode, or no sliding in modern terminology. It's rare that you get such a beautiful straight picture. This is a pneumothorax in this case. Now there are some other helpful signs. However, they're not always present, and you sometimes have to go looking for them. The first one is lung point. Lung point is the best and most accurate sign, and that rules in a pneumothorax. Lung point is where the edge of expanded lung touches the pleura, the visceral pleura, parietal pleura, and you can see it moving in and out or across the area of free gas. Unfortunately, it is not present when you have a completely collapsed lung. Lung pulse, on the other hand, is thought to be the transmitted cardiac pulsation, and that'll be only transmitted across expanded lung. That's just a regular beating. And that will rule out a pneumothorax, but only at that point where you record the lung pulse. B lines are similar. B lines or any pleural line abnormality, any divot in the surface of the white line will rule out a pneumothorax at that particular point. It is important to say though that the B line has to move. A fixed B line can simply be a sign of apleurodesis. So here is an example of a lung point. Remember, it's the only reliable sign, but is not present in a complete pneumothorax. You can see it there on the right. See how the pleural line looks continuous. You can't see any break between the pneumothorax and the lung. Here's another one on the left. You see those tiny little pleural line abnormalities flicking on the left side of the screen, and then dull white line on the right. And this last one is what Vopp called a hydropoint. This is actually hemopneumothorax. There's free gas in the pleural space on the right, and on the left we actually have free fluid, I think blood, and as the lung expands, the blood is pushing the free gas to the side and back. It's almost like a reverse curtain sign. If we put the M mode through a lung point, it gives a picture something like this: straight, then shells, straight, then shells. Unfortunately, it is possible to get mimics of this when the patient, for example, is holding their breath or a little bradycardic. Lung pulse is more subtle, but if you look carefully, you'll see that there's a regular spaced beating underneath the pleural line that's not present above. And finally, here's a picture of a tiny B-line on the screen left. This patient I'll show you the X-rays of later and the M modes. As you can see, it would be quite hard to decide whether you had relative movement in a patient like this. Just for comparison, this is the apex on the other side. Now there is one tool we can use if we have time and the patient can help, and that is gravity. Air rises to the highest point. Now, if the patient is erect, air rises to the cupola of the lung, which actually becomes a little bit hard to scan. It's hard to put your probe in the supraclavicular fossa, and there isn't a great deal of slide to be seen from this point. It's much nicer if you can lie the patient back or semi-reclined so that the air rises to the anterior surface of the chest. Likewise, if you really want to show that it's free gas, you can roll the patient on the side and document that the gas moves to a different area. Very well if you've got plenty of time. So let's recapitulate. The signs we are looking for are sliding versus no sliding. And old terms for these were marching ants, twinkle seashores, and then no sliding was barcodes and stratosphere sign. Secondly, we look for lung point if we've got lots of time. We look for lung pulse and B lines. And A lines are not of any use. They're equally present beneath ribs and beneath pneumothoraces. The only use, I think, for an A line is to say that you are scanning at 90 degrees to the pleura if you're picking up A lines. So the fourth lesson would have to be that if you're really serious about finding a pneumothorax, you have to look harder, you look more, right round the surface of the lungs. And the more you look, the more accurate will be your investigation. So ultrasound is sensitive for pneumothorax. If you have a sensitive test, when the test is negative, you can rule it out. However, ultrasound only rules out a pneumothorax under the probe, in other words, where you have put the probe. This is where we lose a little bit of sensitivity if we don't scan. If you don't scan the cupola, if you don't scan behind the scapula or roll the patient, there's where you will lose your sensitivity. There is a minor acquisition error, and that is determining what sliding is. You have to be sure you really have true sliding, more movement beneath the pleura than above. We get false negatives with movement artifact and false negatives with loculated pneumothorax. This is one of the, as I said, a straight probe was a mixed blessing. You can see the pleural edge very clearly, but you also see the extra movement very clearly. And if you looked at this, you would think that that is not a barcode, that's not a stratosphere. There's too much movement. But if you look very carefully, you'll notice that pretty much all of the ripples and wrinkles that you see underneath the edge are continued above. This was, in fact, a pneumothorax. The issue with lung ultrasound is that it's not specific. In other words, if it's positive, you can't rule a pneumothorax in. And this is most difficult when you have abnormal lungs, because there are many causes for lack of sliding. And I think this is where the majority of our errors come in. The false positives we have occur in situations such as pleurodesis, be it iatrogenic or physiological or temporary. We have the problems with BULLAE, which don't expand or slide, with emphysema, and I would postulate, I think that there may be a physiological area of equipoise where there is minimal sliding. Come back to that one later too. So here is the M mode from the case I showed you earlier. You can see it looks like a beautiful barcode or stratosphere. You could say this is highly suggestive of pneumothorax, but this is the patient's erect chest X-ray, and again going back to the lung ultrasound, on the left we had that tiny B line appearing on near the center of the screen, which says that this is not a pneumothorax. It was a case of bullous lung disease. A second problem is subcutaneous emphysema. When you've been scanning for a while, your eye is drawn to the straight line of gas, and you can be forgiven for mistaking this for a pleural edge. You really have to make sure that you identify a rib and that what you're calling the pleural edge actually starts deeper to the rib. In this particular case, the true pleural edge was, as you see over here on the left, about a centimetre deeper. Now, emphysema like this doesn't move, as you can see in this clip. However, it's rather hard to decide whether the pleural edge on the far left has any relative movement. There's some degree of pleural of heave, but do we actually have slide? This is exactly the case where you should be putting the M mode down, and I think you can see that there is some extra movement just in this small area of true pleura. This was the one I mentioned earlier. I suspect, and I've seen this I think in slim young girls, an area close to the midline where you can document no sliding. You know it's close to the midline because you can see it's a cartilaginous rib, and that's why the pleural line extends as visible beneath the rib. And on this particular picture, you can see just a hint of sliding on the far left and on the far right. If I put the M mode on this exact case, put it to the edge, you can see on our left picture that there is movement below the pleura, but on the picture on the right you can see a good barcode line. So there was an area where you can document no sliding. I'd love some studies on this. The other problem we have is pre-existing lung disease. Now, any scarring may prevent free gas from rising to the highest point, so that ruins one of the assumptions we make both with lung scanning and with erect chest X-ray. These patients need a CT scan whenever feasible. I always think it's important that when you use any tool that you're very familiar with the limitations, that you can rattle them off just as quickly as the advantages. Lung ultrasound only assesses surface area. The other way to say this is that you don't know how deep your pneumothorax is. If you're going to do an accurate study, it takes a long time. You have to take your probe right round every rib space from front to back. If you don't do this, you may miss a loculated pneumothorax. Here is the CT scan of the earlier patient with the subcutaneous emphysema. As you can see, the emphysema was extensive, and of course it meant there had to be pneumothorax, but as the CT reveals, the pneumothorax was actually only very small. So in summary, if you're considering doing lung scanning for pneumothorax, you've got to ask yourself these questions. The first thing is, if my scan is negative, what are the consequences of me missing a very small, for example, apical pneumothorax? Is it important in this patient? The second thing to ask yourself is, what's the chance that this patient has pre-existing lung disease. Thirdly, if I do find an area of nose sliding, how important is it that I do a thoracostomy? Do I have time to wait? Do I have any other options? And finally, I have to ask, what is the risk of the alternative test? And having just from an arrest in CT only yesterday, I think this is not an insubstantial risk. So in summary, if you're considering learning lung ultrasound for pneumothorax, remember you're juggling the risks versus the stakes. No one test is superior to the rest. They all have their place in clinical management. Lung ultrasound gains in sensitivity, but it's not 100% sensitive. Those last few percent are operator dependent. You'll look 3 sorts of movements: heave, slide and twinkle, and you have to separate them out. The further you look, the harder you look, the more accurate you will be. Pre-existing lung disease is going to damage your accuracy. And finally, remember that when you're looking for a pneumothorax, you're only documenting the surface area. If you want depth or size, you're going to need a CT.